Hello friends, I am Kunal Yogesh Chandra, prosthetist and orthotist, presently working in KCGMC Karnal and former assistant professor at SAMS Indore. Today I will discuss the Clubfoot and its Ponseti management and Ponseti techniques for correction of the Clubfoot or CTV, that is congenital talipes virus. This clubfoot is also called congenital talipes virus. So there are different deformities. This is the typical picture of a clubfoot. Next, please. Clubfoot has different deformities, mainly cavus, adductus, virus, and equinus. Cavus is the excreted arch, medial longitudinal arch. So there is high arch actually. If you are looking the foot, then this is the medial longitudinal arch, and if it is excreted, then it is the cavus. Next deformity is the adductus or forefoot adduction. It is goes inside the. And next is the virus deformity, and then equinus. So it makes cave, CAVE, and this is the sequence of correction of the deformity. This should be followed, otherwise there is chances of rocker bottom foot. Clubfoot deformity, subtalar joint at its extreme range of supination. In this diagrams you can see there is a subtalar joint at its extreme range of supination. So there is supinated foot, fully supinated foot, and this deformity, clubfoot deformity. And one famous doctor, Dr. Ignacio Ponseti, he was famous for treatment of the clubfoot. He started treatment in 1944. In 1950 and popularized in 2000. He written a book in 1996 when I take admission in for graduation in NIH Kolkata, and that was the year 1996. And there is excellent long-term results, relatively simple techniques. It's because very minor surgery is needed, along with manipulation, casting, and tenotomy and dressing. These are the different processes. So first correction of the deformity, and then maintenance of the correction. Next, please. Now we'll discuss why the Ponseti method of clubfoot correction works. This is the topic, why the Ponseti method of clubfoot correction works. Because in history, different people, different doctors have tried to correct the deformity, but those surgeons or many persons were not so successful as Dr. Ponseti, because Dr. Ponseti understands the kinematics of the tarsal bones and subtalar joints. So detailed understanding of, complete understanding of the kinematics of the tarsal bones and subtalar joint is needed for the correction of the different deformity of the clubfoot. The Ponseti technique of the clubfoot manipulations. The Ponseti technique is effective because it takes advantage of kinematics of the subtalar joints. This techniques it takes the advantage of kinematics of the subtalar joints. So Dr. Ponseti written a book that is titled Congenital Clubfoot, Fundamental of Treatment. According to this book, according to Ponseti, Dr. Ponseti, a well-conducted orthopedic treatment based on a sound understanding of the functional anatomy of the foot and on the biological response of young connective tissue and bone can gradually reduce or almost eliminate this deformity in most club feet. So this treatment is effective. A sound understanding of the functional anatomy of the foot and biomechanics, pathomechanics should be understood fully. And as because there are orthopedic surgeon and pediatric orthopedic surgeon, those trained in management of club foots are very few in numbers, and they are also busy in different other surgeries. So I think one healthcare professionals like prosthetist and orthotist may be trained for this treatment of the club foot, because they are well trained in plaster or casting, and they have also a sufficient knowledge for the biomechanics and kinematics of the foot. So to cover the large population of the India with club foot, prosthetist and orthotist may be trained for this management of the club foot. Next please. This is the, in picture you can see the deformity of the club foot. Here the foot is fully supinated. So principle number one is almost all the motion of the foot occurs around the talus. All the motion of the foot occurs around the talus. So we focus on talus. Talar head is works as the fulcrum for deformity correction also during the casting. And calcaneal motions, flexion and extension, abduction, adduction, eversion, inversion. So if you are looking at the calcaneus, then it flexion and extension means plantar flexion, this is dorsiflexions, then inversion, and this is the eversion, and adduction and abduction. These are the different movements that can occurs on the calcaneus also. You can see. Next please. So almost all the motion of the foot occurs around the talus. At the ankle joint that is the talocalcaneal or ankle joint, that is tibio-talar joints, and talocalcaneal joint, that is the subtalar joints. Talocalcaneonavicular joints, that is the acetabular fetish also. Good. Next. So next, second principle is the calcaneopedis block. The calcaneopedis is unit is the all bones of the foot except the talus. The calcaneopedis blocks, the entire forefoot moves with the calcaneus around the talus. So you can say, if you are supposing there is talus, then other foot bones of the foot moves. I don't have the skeletons or a model for a skeleton, so we can show the movements of the foot actually. But all joints except the talus may be moved around the talus. Next. One may consider the subtalar motion, one between the talus and a fused group of the tarsal beneath, permitting simultaneous rotation at the talocalcaneal and the talonavicular articulations. The correction of the rear foot and mid foot can be accomplished by the abduction of the foot. Abduction pressure on the first metatarsal lever can motor movement of the calcaneus. This is the subtalar joint center of rotations. At the subtalar joints, their movements different. inversion, eversions, supination, and pronations. At taloconchlear introsseous ligaments and corresponds closely to the ankle center of the rotation. This is the axis of the subtalar joint. So 21 degree here and 69 degree. Okay, next. Anterior tibial tendon line of the pool is medial to subtalar joint axis, causing inversion, transferring lateral to axis causes eversions. Ponseti method of treating clubfoot deformity follows normal kinematics of the subtalar joints. So there is adduction, inversion, flexions. These are the deformities. Flexion means the plantar flexions, and adduction is converted to abductions, and inversion go to eversions, and flexion go to or plantar flexion go to dorsiflexions. So this is the foot adducted, inverted, and this equinus or plantar flex positions, and after flexion. Next please. Now the reduction of the talonavicular joints. For this we again locate the head of the talus. It is just distal and anterior to the lateral malleolus. In newborn clubfoot, first cast, forefoot pronated on the rear foot, that causes cavus. Forefoot pronated on the rear foot causes the cavus. So we generally elevate the first ray. Only elevation of the first ray reduce the cavus deformity. So in first cut, you can see this is the elevation of the first ray. Next please, let's say in diagrams. So elevate first ray, but the foot looks worse, even more supinated. In this diagram, in first cast, it is looking that the foot is more supinated or more deformed, but actually we are reducing the cavus. So first deformity, that is the cavus is reduced first, and then adduction, and then virus, and then last one is the equinus should be corrected, so that the rocker bottom foot may be prevented to occur. So next principle number 4 is correction occurs by allowing normal tarsal bone kinematics. Next, dorsiflexion and plantar flexions of the ankles occur on the ankle joint, that is the tibio-talar joints, and this pronation and supinations at the subtalar joints. This is the modals, and this the heel and virus, and if you are pressure making here, then if you are making the force to abduct, then the virus may reduce. Next please. And this is the valvular position due to the this force by lateral sides. So supinations consist of inversion, adduction, and plantar flexion. These three movements are present in supination, inversion, adduction, and plantar flexion, along with the heel virus. Heel goes in the virus. If the foot is supinated, then heel goes in the virus, and there is inversion, adduction, and plantar flexions. And just opposite is the pronations. Here the abduction, dorsiflexion, and eversions, and heel goes in the valgus. So opposite to the supinations. And here you can see, if you are going on the toe out on here is the pronated foot, this heel, but if you are going on standing on the toe, this go into this supinated virus of the heel. Okay, next. As the foot is abducted, the that is apparent supination, spontaneously corrects to the neutrals as the foot is abducted. So abduction of foot is necessary. This is the kinematic coupling. As the foot is abducted, the inversion spontaneously corrects to the neutral. The forefoot is never pronated. And without touching the calcaneus, the heel spontaneously comes out of the virus as the foot is abducted. So abduction, forefoot abduction. Abduction of the foot is very essential. Full abduction is necessary. Now the Ponseti method of the treated Clubfoot follows normal kinematics of the subtalar joints. Again, adduction, inversion, flexion goes in the abduction, inversion and extension. So next principle is inversion and eversion are kinematically coupled to abduction. And this is the kinematic coupling. In this diagrams, a skeletal model is used to demonstrate the kinematic couplings. And elevation of the first ray, again reducing the kyphus deformity of the foot. And this is the first cast where the first ray is elevated and foot goes in more supinated positions. So eversion is kinetically coupled to abduction and the foot is never pronated. And heel virus and abduction are kinematically coupled. So next, dorsiflexion of the calcaneus through the subtalar joints and abduction are kinematically coupled. So again, if you are making the foot in full abduction, then the foot goes in maybe plantar flexion or equinus deformity may be reduced in somewhat. This is the final cast of the Ctev in which the forefoot is abducted around 70 degree after tenotomy actually, and before tenotomy it is 50 degree abductions. And this is the another view of the final cast. Here the foot in full abduction. So this full abduction of the foot, the anterior process of the calcaneus comes out from the underneath the talus and it dorsiflexes into the sinus tarsi, and dorsiflexion of the subtalar joint is achieved by the stretching the posterior capsule and the lateral tether is stretched. So this is the next fifth principle, full abduction of the foot is necessary to effectively treat the club foot. This is the main principles. So why is 70 degree of abduction necessary? In cast you can say it looks so abnormal, but normal abduction of the foot is around 70 to 75 degree. So during final cast we go for 70 degree abduction. So it is necessary to restore the normal calcaneal angle. Is necessary for calcaneus to come out of the virus. Is necessary to properly stretch the calcaneofibular ligament and lateral tether. Is necessary to obtain dorsiflexion of the subtalar joint. So all these deformity, if you are reducing, then for this maximum abduction of the foot is necessary. And as the foot is maximally abducted, the subtalar joint is spontaneously extends and dorsiflexion improves without rocker bottom risk. So here is also abduction necessary, but Dr. Kite made mistake because Dr. Kite was wrong because he did not understand the subtalar joints. And Kite's mistake was that he blocking the calcaneus from the abducting causes iatrogenic deformation of the mid-tarsal bone and joints. So, Dr. Kite blocked the calcaneus, and so uh, a kinematical coupling was not possible. Like so, secondary deformity occurs due by the Dr. Kite. He was not so successful. They had made mistakes. And after final cast, before final cast, if the deformity is all corrected except the equinus, we go for percutaneous Achilles tenotomy. In most of the cases, tenotomy is necessary because full range of the dorsiflexion doesn't occur by the casting. If the deformity is minimal or moderate, minimal mainly, then may be possible that there is no need of the tenotomy, but many cases need the tenotomy of the Achilles tendon, that is the percutaneous Achilles tendon, that is done in the office procedure or OPDs. I working in OPD of the orthopedics since last 8 years, and here this Ctev clinic or Clubfoot clinic is going on. I have also applied different corrective cast for the Ctevs. Next, please. So foot in 70-degree external rotation and 10-degree dorsiflexion, and cast should be always above knee cast. If you are applying the cast, that should be applied above knee, and knee should be at generally 90-degree flexed. But if there is chances of slippage of the cast, then that knee angle may be increased to 110-degree. Okay. So 70-degree abduction, final cast after the tenotomy. This cast is for 3 weeks, last for 3 weeks. Generally, other cast we change from weekly or generally 5 to 10 days, but this last cast should be for 3 weeks after tenotomy. And after removing this final cast, we need foot abduction brace unbracing, and that is the very important. So don't underestimate the power of bracing, because it maintains the correction of the all correction of the deformity. So if you are fail and properly use the bracing or follow-ups, then there are chances of relapse. So again it may occurs. So you can say that पुनः मुश्क भवा, तो जहाँ से आपने शुरू किया वहीं फिर पहुँच जाओगे, जो भी किया धरा हुआ है सब खत्म हो जाएगा. So bracing is important. Next, please. Two most significant factors in preventing relapse is 70-day abduction or more, and long-term night abduction brace up to the 4 years. Remember this, long-term night abduction brace up to the 4 years, and final cast should be 70-degree abduction or more. So it is necessary for correction and then maintenance of the correction by the bracing. And for scoring of the deformity, we generally use Pirani scoring. This is used 0 to 6 scales, in which curved lateral border, medial crease, talar head coverage, and posterior crease, rigid equinus, and empty heels. These all are scales are used for the scoring of the severity of the deformity of the foot, so that we can last from beginning to last. We can judge the how much correction have been done and when the tenotomy is needed. So this is the Pirani scorings, and here 0, 0.5 and 1. 0 is normal and 0.5 is moderate and 1 is severely deformed. If the foot is severely deformed, this is the one score. So all the scores are summed up or added, and that will be reference for the correction of the foot. So foot abduction brace is very essential. Bracing is very important part of the treatments and maintenance of the uh, corrections. So heel shoulder width apart, and this should be adjustables, open toe and open heel, and external rotation should be 70 degree in the deformed sides, and the normal side should be 40 to 45 degree. You can see this is the abduction bar, and this is the shoe with open toe. Heel should be also open, haircut should be present, but there is not, so that we can see the that the heel goes inside and on the heel of the shoes properly fitted, and this is attached just like this and this. So this is the around 70 degree abduction, full abduction of the foot, and this is also in this may be reduced by the 40 degree or 45 degree to the normal sides, and affected side should be 70 degree abducted. There are different braces. This width of this brace should be heel shoulder width apart, means shoulder width should be measure of the patient or the child, and this should be the width of this abduction bar also. So there are different orthosis. You can see this single one, but this abduction brace should be, foot abduction brace should be preferred on this braces like this one, like AFO corrected straps, and this also you can say, and this. So different types of braces are present. Next please. And this is the Steinbeck brace that is used by the child, and this is bar is outwardly bent so that the dorsiflexion as possible, and somewhat everted foot is also as possible. Mainly for dorsiflexion of the foot, this should be outwardly bent, this process. Okay, next please. So there are different, you can see the different braces, and different time period they have developed by the different professional or artisans. Okay, next please. This is the diagram picture of Dr. Ponseti. They is treating the Clubfoot patient. So he was famous for this Clubfoot management. Dr. Ponseti. Thank you very much for listening. Thank you. Have a good day.